So I'm going to give you the take-home message for today. So we begin the morning with the hepatitis C first sessions, in which we address 3 questions. The first question is still a role for personalized treatments? And as Graham mentioned, good medicine is always personal. Detailed pre-treatment assessments allow optimal therapy, but pre-treatment assessments reduce access. So therefore, don't let the perfect be the enemy of the good. I try to demonstrate to you that we have now solutions for any treatment, DA treatment failures, and we have options in 2019. And even if some patients could relapse after these treatments with glipib, soft-Velvox, and soft-GP, we are achieving treatment in nearly all patients. So no real issue for treatment failure. Stan addressed the fact that are there still difficult to treat populations, and there is no more difficult to treat population, in fact, but there is 3 main remaining difficulty, which are mainly related to either drug-drug interactions, adherence, and the safety of DEA. Even if safety is fair, we need to monitor our patients in order to recognize severe or very rare adverse events that can occur. Then we had a very nice state-of-the-art lectures on access to treatment and linkage to care given by Michael. And he really nicely shown that barrier to HIV therapy still exists despite the availability of really near universal therapy efficacy. Barrier exists at multiple levels, provider, patients, health systems. While every country have unique challenge, some barriers are common across all countries, and the goal of global eliminations of HIV is going to be hard to achieve, and it may start by micro-eliminations project, and he showed us several examples of this micro-eliminations project. Then Mitch deal with the treatment of HIV decompensated cirrhosis patients, and he nicely underlined the fact that the SVR in this population is lower, 85 to 95%, and achieving SVR in the patients with advanced symptomatic cirrhosis may not improve quality of life. It may induce the patients into the mild purgatory. It's not appropriate for all patients, and the best patients for these treatments with patients with low MELD and no liver transplant candidate. He otherwise stressed the fact that we have some challenge of treating these kind of patients. Patients may decompensate further during treatment. Hospitalizations may impact compliance. Agents containing protease inhibitor cannot be used in this setting. High rate of acute kidney insufficiency limit the use of soft-containing regimens, and also to recommend that it's difficult to use ribavirin in these situations. And finally, patients with cirrhosis who achieve SVR remain at increased risk to develop hepatocellular carcinoma and to have additional episodes of hepatic decompensations. Then we move to the second hepatitis C session, in which 3 issues were discussed. The first one was HIV therapy, the last challenge, and Stefan do a very nice overview on 13 points. And they say that we still have several challenges in small populations like the decompensated cirrhotic patients, but these populations is disappeared very rapidly. There is some challenge remaining in the large populations, especially the challenge of HCC surveillance after SVR. There is some challenge that are key to reduce the burden of the disease in geographic regions and populations, and the linkage to care and access to treatment is a key problem for worldwide. And one challenge to indeed eliminate HIV globally is the vaccine development. Then we move to the treatment of co-infected HCV and HBV patients, and Robert nicely reminds that all patients should be screened and should be tested for HBs antigens prior HIV treatments, and at least prophylaxis with nuke analog should be administered in all patients with HBs antigens positive, and in immunodeficient HBs negative and the HBs HBC positive patients, we need to do more screening and to treat these patients and continue at least until 12 weeks after HIV treatment terminations. Immunocompetent HBs antigens negative anti-HBC positive patients probably do not need specific monitoring for possible HBV reactivations. Antonio Craxi and Massimo Levrero deal with the questions of do DAs decrease the risk of HCC, and so they separate the thing between the occurrence and recurrence. And Massimo reminds us that viral cure does not eliminate HIV-induced epigenetic change. So the risk of HEC remain, and what is now clear through the literature is that successful antiviral therapy reduce but does not eliminate the risk of HEC development. Looking to the HIV recurrence after DAA, the take-home message is that patients with HIV cirrhosis and a previously cured HEC remain at risk of cancer recurrence after HIV eradications. It's clear that the risk of HEC recurrence is lower than in non-eradicated patients and is proportional to the previous HEC recurrence and tumor size. And the primary data in patients with previous cure HEC suggest that the response rates to DAA is excellent and that the survival might be higher in SVR patients despite HEC recurrence. And the true message is DAA should not be withheld in these patients. Then we had an outstanding lecture from Michael Mans about autoimmune hepatitis. He reminds us the key diagnostic features of autoimmune hepatitis, reminding the test that we could use, the score that we can use. And he also reminds us about the therapy and about the first-line therapy using prednisone or prednisolone plus azathioprine. And he reminds us also the second-line therapy with cyclosporine, tacrolimus, mycophenolate mofetil, and the other compound that can be used in this setting. More interestingly, he gives us some data on the rescue regimens with anti-TNF, anti-CD20, and anti-B cells, and he gives us some insight about the future therapy of autoimmune hepatitis with anti-CD3, low-dose EL2, and adaptive transfer of Tregs. Then we move to the afternoon where we talk about NASH, and the first sessions were devoted on three main topics: how to characterize NASH. So obviously Pierre Bedossa, as usual, explains us that NASH is histology. So it's defined by histology. Liver biopsy is a robust procedure that can assess all components of NAFLD if performed by trained physicians. He suggests that a submillion patient's productions of the result is more appropriate than dichotomous classifications, but obviously recognize that liver biopsy is not the screening tool for screening NASH. And then Laurent gave us an algorithms on how we can do by using FIB4, NFS as first-line tools, and then using the transient elastography as the second-line tools in order to assess and to characterize NASH. And this is the famous dancing that they have together from now 2 years, in which clearly the non-invasive test is a good way to make a triage in large unselected populations, and liver biopsy is a good way to assess in selected populations or in clinical trial. And the best use as an integrated systems to allow more efficient evaluations of patients with NAFLD. Elisabetta showed very nice presentations on lifestyles and demonstrate that lifestyle change is an effective treatment modality for curing or controlling NAFLD or NASH. However, lifestyle change is difficult to achieve, and she reminds us that there is three essential components: cognitive behavioral therapy, dietary modifications, physical activity change. They are all required for a successful outcome. And so it is a multidisciplinary, holistic, individualized approach which is needed and which is key. And there is moreover effort, societal effort to change an obesogenic environment which is strongly needed. So we have to find, again, Coca-Cola. Then Arun usually show and explain us how we can, the therapeutic advance in NASH. He nicely shown that bioasteroid can improve liver histology, but overall the grad quality of all the study are quite low. If we look at the current statute of drug treatment and the impact on NASH resolutions, beside vitamin O, pure glitazones, there is all the other compounds that have been already released with different populations, different endpoint evolutions, but globally there is at least 4 or 5 drugs that are currently have an impact on NASH resolutions. In terms of fibrosis improvements with the current agents, Arun also show us the result from all these compounds that have been presented at the various meetings and at the last SLD meeting. And clearly, he really liked the GLP-1 receptor agonist because he has both the potentials for cardiometabolics as well as liver benefit, and he had discussed that after with the diabetologist. So the next session was devoted to a discussion between hepatologist and diabetologist. And so the Bertrand Cariou, which is the diabetologist, have a take-home message for the hepatologist. We should screen type 2 diabetes in patients with NAFLD. And for that, in clinical practice, it suggests us to use the FPG and the hemoglobin A1C in order to assess for type 2 diabetes. Lawrence Sefati remind the diabetologists that they have a very poor knowledge about NAFLD with his TACT. So he explained that only 5% of diabetologists give the right answer on the prevalence of patients, of diabetic patients who have NAFLD, and on the gravity of the fibrosis in patients with NASH among the diabetics. Remind the fact that 68% of diabetologists are not use non-invasive methods for the severity of liver disease. And he reminds us that FIB4 should be the first-line method to screen for type 2 diabetes patients for NASH, and FibroScan as a second line for detections of advanced fibrosis. And then which patients to refer to liver clinic. He gives us a very simple algorithms using FIB4 and then FibroScan in order to address to the hepatologist only 30% of the type 2 diabetics with suspect NAFLD. Finally, Jean-Michel Petit, for the diabetologist, reminds us that in diabetic patients, antidiabetic drugs should be adapted to the diagnosis and the severity of NAFLD. Pioglitazone is effective for long-term treatment of patients with NASH with type 2 diabetes. And he also explained that GLP-1 analogs and SGT2 inhibitors have benefits against NAFLD in patients with type 2 diabetes. And Harun stressed them about the utility of this molecule, and he pushed the diabetologists to go a little bit over their own guidelines. And the diagnostic of cirrhosis should lead to the change of the management of the diabetes. And clearly, in diabetic, we have to keep in mind that HbA1c measurement is not accurate in patients with cirrhosis. There is a protective effect of metformin, and there is cautions to adverse effect of diabetes therapy. Now we move to the awards and to the outstanding presentations from Massimo about HCC today and the future. He reminds us that liver cancer is the 16th leading cause of death globally, and the incidence is growing. There is a 47% of increase, and this increase is most pronounced in the high sociodemographic in the developed country, including, for example, Netherlands, UK, and the USA. It reminds us the progress that we have made throughout the years about the treatment of HCC with the different opportunity and solutions that we have now according to the evolutions of the disease, and is also stressed on the goal range of cancer immunotherapy trial triggering a reversal of T-cell exhaustions with either stimulating agents or blocking agents. Then he moved to the EASL recommendations about public health policies and appropriate cancer surveillance, and he reminds us the fact that HBV vaccination is a very good way to prevent the occurrence of HCC by the example of the Chinese experience. And he also reminds us that we are not doing an appropriate cancer surveillance, and if it was done in Japan, clearly in Europe or in Hong Kong or in the US, we are far from ideal in order to make an appropriate cancer surveillance, and we need to do some efforts in order to do that. Finally, it reminds us the particularity of HCC now with not only clinical features, but also genetic alterations, molecular classifications, that is going to link in the near future to liquid biopsy and then to a personalized medicine. And that's really a good way to go to the future of HCC. Finally, we had these sessions on metal and the liver, and Peter Ferenczi give us this take-home message for Wilson disease. And we have understand by his presentation that is a highly variable clinical presentation. There is no clear-cut evidence for correlations between genotype and phenotype. And the message for hepatologists is that we need to consider Wilson disease in any patients with unclear liver disease because this disease is treatable. Then he explained us the link between NAFLD and the copper, which is called the copper connections, and the NAFLD. And so in patients, we have to take into account that low hepatic copper content is observed in lean NAFLD, and there is interaction with hepatic iron. And finally, Antonello gave a very nice presentations on iron and the liver, and remind us that the liver is the main storage site of iron, but also the central regulator of body iron homeostasis as the main source of hepcidin, the iron hormone. Genetic loss of hepcidin or hepcidin ancillary regulators, such as HEFE, cause hereditary hemochromatosis, the paradigmatic human iron overload disease. But the loss of hepcidin-producing liver mass may cause systemic non-hemochromatosis, iron overload, and liver disease factor mediator that modulate the capacity of the liver to produce hepcidin may cause hepatic iron overload and affect liver disease progressions. So manipulating hepcidin synthesis activity or hepcidin hormone replacing strategy represents the first etiologic cure for iron-related disorder, and that's really the new information that we can get of this meeting, is that we have now new tools that we can use in Iran with the liver. Thank you for your attention, and I would say a great thanks to all speakers who provide the presentations.